Thank you for the kind introduction, and thank you for having me speak. I'm going to be talking today on cervical and lumbar arthroplasty in the spine. It's an up-and-coming area in spine surgery, and it is an area of a certain amount of controversy. I'd like to give you guys a little bit of a background on the field and why there's controversy, and also I'd like you to understand the rationale for arthroplasty. I'd then like to go over the clinical data, and then I'd like to go over a few cases, and then I'll open it up to questions. So I think I have about a half hour, so I'll get started. Okay, so with respect to the spine, as you know, in orthopedics, we get the degeneration throughout the musculoskeletal system, and that includes the spine. In the spine is a somewhat unique environment in that the disc, the soft tissue disc part of the spine, uniquely compared to other joints, the disc is what degenerates first. The disc contains proteoglycans and high water content. As we get older, the proteins and proteoglycans in the disc degenerate. The water content of the disc is lost. That manifests as a black disc on a T2 MRI, and the disc loses height, so the disc starts to collapse. As part of that process, he develops some low-grade scoliosis, spinal stenosis, and leg pain and back pain. As the discs continue to collapse, the facet joints carry an increased amount of load. In the native state, the facet joints carry about 20% of the load of the back, and the disc carries about 80%. As the disc collapses, more of the load of the back is transferred to the facet joints, and after the discs collapse, then the facet joints start to degenerate. So the facet joints in the spine degenerate last. That's an important principle because that suggests that you can treat the disc first and preserve the rest of the spine. This is a longitudinal study published from Japan. The first slide there on the left, on the far left there, is a 66-year-old patient, and then the middle is 4 years later, and then the slide on the right, the x-ray on the right, is 12 years later. So what you see on that first image there on the left is some low-grade disc degeneration at multiple levels. 4 years later, the patient has moderately increased disc degeneration throughout, and then finally 12 years later, the patient is starting to develop some scoliosis. The takeaway point here is that the degenerative process in the spine begins in the disc, and it's progressive. Okay, the traditional treatment for advanced spine degeneration in the cervical spine is an ACDF. It's a good surgery, and it's been done for decades. In the lumbar spine, there'd be some form of an anterior or a posterior spinal fusion performed. So if the ACDF, the anterior cervical discectomy and fusion, works so well, why don't we just do that to everyone? The truth is that in fusion of the spine and fusion of the neck, the long-term results tend to be pretty good. However, there are complications. The main complications are what's called pseudoarthrosis. That's a failure of spinal fusion. And the other main complication is what's called adjacent segment disease. That's where you do a fusion, and then you get increased stresses above and below the fusion, and the rest of the spine starts to wear out. So let's look at some of the results of ACDF. Dr. Bowman in Cleveland in 1993 published one of his many classic papers. This particular paper was a 6-year follow-up study of 120 of his patients who'd undergone a non-instrumented ACDF. And if you look here, there's a fusion there, but there's no plate, there's no screws. Back in the 1980s and 1990s, Dr. Bowman didn't have fancy screws and plates to put in the spine. So he just put a wedge of bone in the level he was trying to fuse and waited for it to fuse. From this paper, he reported that 80 out of the 120 patients at 6 years had no arm pain and no neck pain, so that's pretty good. The overall results were excellent. But about 15 to 20% of those patients had a pseudoarthrosis. That big wedge of bone, that big wedge of bone that was stuffed into the disc space, in about 15 to 20% of cases, it didn't fuse, it formed sort of a fibrous mass. And those patients did not have a bony union. They had continued micromotion there, and they still had continued pain, and frankly did not do very well at all. But still, the overall results were good. 80 out of 120 did very, very well. So from this paper and others like it, we say that ACDF is considered a gold standard surgery. Other investigators looked at ACDF in a bit more detail. Brodke in 1992 noticed that when you do multiple level ACDF, that there's a higher risk of complications. And what Brodke found was that if you do a one-level anterior cervical fusion, About 94% of those patients will go on to a solid fusion, and they'll do great. They have minimal arm pain, minimal neck pain, have very, very good results. If you do a 3-level anterior cervical fusion, then the fusion rate goes down to about 83%. That means about 17% of those patients have continued pain, continued symptoms, and 83% of them do very well. So you can see when you have more complex multiple level surgeries, the results are not as good. Bowman and other colleagues confirmed the same findings. Bowman reported with multiple level ACDF only a 73% fusion rate. That means that 27% failed. So the more you fuse, the more your chances of failure. And that's an important downside. The next big problem with fusion is what's called adjacent level disease. Bowman, Hillebrand, and others noted that when you do a spine fusion, you have a very nice fusion there, but what you're doing is you're placing increased stresses above and below it, because now this level can't move the way it used to. That means there's extra motion above it, extra motion below it. And in this particular x-ray, I think it's from Hillebrand's paper, this shows a spinal fusion patient 10 years after the surgery. And 10 years after the surgery, you know, the fusion still looks good, but the level above, the level below is starting to wear out. So those increased mechanical stresses may be associated with increased degeneration above and below the fusion. So if you do one fusion, that gets you another fusion later in life. That's one of the reasons that I try to avoid doing fusions in young patients, because if you do a fusion in a 30-year-old, 15 years later, when she's 45, then you're just buying that patient another spine fusion at the level above or below. Now, obviously, there could be a genetic component to this. It doesn't mean that the adjacent level pathology is due to the mechanical stresses. It's possible there's a genetic component as well. We don't really know for sure, but we have investigated this question a bit. Goffin and colleagues in 2003 did a 5-year follow-up study on 180 patients, and about half of those patients had a cervical spine fusion, half of them did not. Now, what he did was he tracked over a 5-year period, radiographic development of degenerative disc disease. And in the patients who had had a previous spinal fusion, 92% of those patients developed radiographically significant adjacent level degenerative disc disease above and below the fusion, 92% of them. Now, in the patients who did not have any spine surgery at all, that group of patients over a 5-year period, about 34% of them developed radiographic changes. So there's clearly some sort of a genetic component to this adjacent level of degeneration, but there's also a strong component associated with the fusion. If you do the fusion, there's a very, very high probability you will get adjacent level changes. If you don't have any fusion at all, you're going to get degenerative disc disease, but the retrospective studies that we have suggest that it's not to the same extent as those patients who have had a fusion. Hillebrand probably published the most famous paper on cervical disc degenerative, cervical spinal fusion, degenerative, adjacent level of degenerative changes. And in his paper of 374 patients, he did a very sophisticated analysis, and he found that if you do a cervical spine fusion, there's about a 2.9% chance per year of the adjacent level degenerating. So after 10 years, there's a 25 to 30% chance of needing an adjacent level spine surgery. So that gets back to my point. You do a spine fusion, that begets more spine fusion later in life. And that's what Hillebrand found, and that's what other people have found as well. This is a chart from Hillebrand's paper, and what he did was year by year, he documented the percentage of patients who needed an additional surgery. You know, after 1 year, about 2% of patients had symptomatic adjacent level disease. After year 2, it was about 1.9%. At year 3, it was 4%. On average, it was 2.9% per year. So when I see my patients and they're considering a spine fusion, I tell them there's about a 2.5 to 3% chance per year of your adjacent levels wearing out. Okay, what about the lumbar spine fusion? The literature that we have is mostly in the cervical spine, but we do have lesser quality literature in the lumbar spine. And Dr. Bervin and colleagues did a meta-analysis. And in the lumbar spine, after 1 or 2 or 3 level lumbar spinal fusion, after 10 years, there's a greater than 50% chance of a symptomatic adjacent segment degeneration. As I said, in the cervical spine and in the lumbar spine, spine fusion begets more spine fusion. That's one of the big things that I counsel my patients on when they're considering spine surgery. So what is the rationale for arthroplasty? It boils down to two things. If you do more than one level spine fusion, the more levels of spine that you fuse, the greater the risk of complications, the greater the risk of a failure of the fusion. That's one rationale. Another rationale is adjacent segment disease. The earlier in life you do a spine fusion, the greater chances there are after 10 years, 20 years, 30 years of developing adjacent segment mechanical breakdown. Now, we don't have proof that that adjacent segment breakdown is strictly mechanical. There could be a strong genetic component to it as well. But I think most would agree that there's a mechanical component to it and a genetic. They're both contributing factors. So arthroplasty was designed in response to the limitations of fusion, the failure rates with multiple level fusion and adjacent segment disease. So in the 1960s, a Swedish surgeon named Dr. Fernström, he passed away I think about 15, 20 years ago, he designed the Fernström ball for the treatment of lumbar degenerative disc disease. And essentially this was a large steel ball. He performed an anterior approach to the lumbar spine. He removed the disc. He placed a steel ball in the posterior third of the disc space. And he reported some of his early results with this. Essentially, a small amount of motion was preserved, and some patients did reasonably well. Unfortunately, a large number of these patients had subsidence of the steel ball. The steel ball would just kind of collapse into the vertebral bodies. I think the mechanical stresses of that steel ball were too great. And ultimately, the long-term results in this design were not very good. So this was a failure. Kostwick and colleagues designed an improved device. This was an elastic arthroplasty device he designed in the 1980s. And Kostwick took this device, he implanted it in animals, and the device consisted, as you can see, of a spring in the center. You had these large end plates on the top and bottom to prevent subsidence. So that's an improvement over the Fernström ball. This spring allows some shock absorption, and it allows a little bit of flexion extension. So he put it in animals, did very, very poorly, lots of failures, and ultimately elected not to try to do any human trials in this, which was probably a good idea. Steffi and colleagues in the late 80s, early 90s designed the Acroflex lumbar arthroplasty disc. They took some of the lessons learned from Fernström and from Kostwick, and they designed the Acroflex disc. So the Acroflex disc consisted of a titanium plate on the top, a titanium plate on the bottom, and then a rubber core in the middle. And this is a design that was removed from a patient that had failed. So he published his experiences with a series of 6 patients in the early 1990s. And did not do so well. There was an unacceptably high rate of catastrophic failures. What would happen was over a period of years, that rubber core would break down, degenerate. I don't know what the process was exactly, but the rubber core failed. It would shear, and then you have 2 metal plates with some shreds of rubber in the center, and you got 2 metal plates rubbing against each other in the spine, and bits of rubber floating all over the place in the retroperitoneum. Not a very good thing. So this design failed as well. So there's a lot of failures. So what's been done, or what we have done with failures, we try and try again. And so the engineers have gone back, they've looked at all these failures, and there's basically 2 general principles of the arthroplasties that have been developed to mitigate and address the failures of earlier designs. So the first principle is that there has to be maximum contact between the arthroplasty implant and the host bone to prevent subsidence. So if you put a small ball in the disc space, that small ball has a low surface area. It'll subside, it'll fail. So you have to have a design that has a large end plate, a large surface area implant that will distribute its load across the entire width and surface area of the vertebral body end plate. So that's the first principle. The second principle is that the articulating surfaces should consist of a synthetic material on a synthetic material. So the rubber articulating surface, probably not so good because it's not really an articulation. The Fernstrom ball consists of metal articulating directly with bone, so that failed as well. The articulating surfaces have moved now to what's more commonly used in the hip and the knee, which is metal on some sort of a synthetic low-friction material, like metal and polyethylene, which is what's commonly used in the hip and the knee. So these are the two principles that seem to have been developed over the years due to the many failures of the disc arthroplasty devices. So the modern designs consist of a large surface area end plates, and then typically there's a synthetic material. Most commonly it's polyethylene. Sometimes it's a titanium-based crystal of some sort, and there's now also a peak on ceramic material. But all of the modern designs do have synthetic material articulating with a low friction surface. So those are the two principles, I think, of the modern arthroplasty designs. So now that you have a mechanical device in the spine, the obvious question is, well, how long is this going to last? And what happens when the bearing surfaces fail? So in the hip and the knee world, they do volumetric wear studies. So this is, I think, a study out of Iowa. And what they did is they did volumetric wear studies on metal on polyethylene total hip arthroplasty designs. And the group out of Iowa determined that the linear wear rates was about 0.1 millimeters per year. After 10 years, there's about a millimeter of wear. The volumetric wear rates determined in the total hip population is somewhere between 30 to 70 cubic millimeters per year. All right. So that's the total hip literature. So what about the spine literature? So similar types of wear studies have been done on the cervical disc arthroplasty devices that are now in common use. All right. Now there's now at least a half dozen or so pretty good modern cervical disc arthroplasty designs, and they all have to go through FDA trials, and they're all made by different companies. I think ProDisc used to be owned by Synthes. Now it's privately owned. Mobi-C is now owned by Zimmer. But the group that designed the ProDisc did the wear studies, and they have a metal and polyethylene design. And with 1 million cycles of wear, they had 2.8 cubic millimeters of volumetric wear. So we know that 1 million cycles of wear corresponds to about 5 to 10 years of wear in the actual patient. So if you look at all these numbers, the takeaway from this is that the wear of the arthroplasties in the cervical spine and the lumbar spine is dramatically less than in the hip and the knee. It's about 1/10 or so what the wear is in the hip and the knee. And the reason is the loads in the cervical spine and the lumbar spine are a lot less than they are in the hip and the knee. Okay, that's one reason. The other reason that the wear rates in the arthroplasties in the spine is a lot less is because the range of motion of the hip or the knee is 90 degrees, 100 degrees or so. The range of motion of a typical arthroplasty implant is more in the range of 10 degrees. So the mechanical loads are a lot less, and the range of motion of spine arthroplasty implants is a lot less. The takeaway from that is that the wear rates are somewhere between 1/10 and 1/100th of what they are in the hip or the knee. So we believe, but we cannot prove, we believe that the biomechanical studies suggest that the spine arthroplasty implants that a modern design should last many decades. If a hip or knee implant lasts 15 years or 20 years, we would expect a spine implant to last several times that. And our goal, obviously, is for these implants to last the remainder of a patient's life. And the biomechanical wear studies that we have suggests that that may be true. All right? So that's the benchtop study. So let's look at the clinical data and sort of some of the standard FDA indications. Let me touch base on this slide real quick. It's a little bit, I should probably find a better place to put this slide, but the general principles for if you're considering a cervical disc arthroplasty or a lumbar disc arthroplasty in a patient, okay, the general principles are that the patient has to have good bone stock. So if there's infection, metabolic bone disease, osteoporosis, these patients will be bad candidates for disc replacement because the disc replacement relies on the mechanical structure of the spine being intact. For a disc replacement to work, the disc has to be worn out, but the rest of the spine, the vertebral bodies, the end plates, the facet joints, all have to be mechanically sound. So as a general rule, the indications for disc replacement are degenerative disc disease only, no other diseases like osteoporosis, soft disc herniations, and the rest of the spine is in good shape because the only thing that you're replacing is the disc. And most importantly is a failure of conservative care. Anyone who's considering an invasive surgery for pain, such as a disc replacement, should really fail, I would argue, 6 months of conservative care. And then obviously if there's any medical contraindications, metabolic bone disease, metal allergy, history of infection, tumor, those are all contraindications to disc replacement. The disc replacement is probably more suited to the active, healthy patient. All right, so we've gone through a number of the failed arthroplasties, okay, from the 70s, 80s, and the 1990s. So finally, in the late 1990s and in the 2000s, we started getting some of the good clinical data and the good clinical outcomes data from FDA trials on modern cervical disc arthroplasty and lumbar arthroplasty designs. So as I mentioned, there's about a half dozen or so different cervical arthroplasty devices that are all pretty good. And universally, all of them have undergone FDA audited IDE randomized prospective studies, level 1 studies. And all the ones that are currently in the market at 1 and 2 years essentially have the same results, which is at 1 year out and 2 years out from surgery, they're equivalent, they're not inferior, they're not worse than a fusion. And they have similar arm pain and similar neck pain improvements as a fusion. So we now know from the early outcomes that they're at least as good as fusion. Okay? Now, if we look at some of the more advanced studies, the Mobi-C implant, early on, they did a 2-level cervical disc arthroplasty study. Once again, an IDE study audited by the FDA, and it was prospective and randomized at about 24 centers across the United States. And in the 2-level arthroplasty study, which was 225 patients who underwent a 2-level arthroplasty, 105 patients who underwent a fusion, in the 2-level study, at 2 years, once again, neck pain and arm pain was either non-inferior or better in the arthroplasty group compared to the fusion group at 2 years. So what that's suggesting is for the multiple level arthroplasty, the multiple level arthroplasty may be more beneficial than the single level arthroplasty. In other words, if you have a patient with 2-level disease, there's more benefit from doing an arthroplasty in that 2-level patient than there is in the 1-level patient. Now that initial publication was 2-year outcomes. Those patients in the 2-level group, they were followed out to 5 years. And once again, this is FDA audited data. And in the 5-year 2-level cervical disc arthroplasty study, the Mobi-C 2-level implant for cervical disc replacement, at 5 years follow-up, in the fusion group, there is a 71% rate of adjacent segment degeneration. In the disc replacement group, there's a 33% rate of adjacent segment degeneration. So that tells us there is a mechanical component to that adjacent level degeneration, but there's also a genetic component, right? Because even if you do an arthroplasty, the adjacent levels will still degenerate, but they're not going to degenerate at as fast a rate or as early as they do after fusion. We talked about non-unions. In the 2-level fusion group at 5 years, there is a failure of fusion rate of 14%. In the arthroplasty group, the failure of fusion rate was 0%, because in an arthroplasty, there's no fusion, so there's no fusion to fail. Now, what about reoperations? Obviously, you can look at x-rays all day long and say the adjacent level's worn out, but a certain percentage of those worn out levels are going to undergo a reoperation. In the 2-level fusion group, there is an 11% rate of reoperation at the adjacent level, and there's only a 3% rate of reoperation at adjacent levels in the arthroplasty group. So, the takeaway from this 5-year study is that the 2-level arthroplasty, the 2-level disc replacement, is superior to a 2-level fusion at 5 years in the variables of adjacent segment degeneration and in adjacent segment reoperation. So if you're counseling a patient, or if I'm counseling a patient on whether or not to proceed with a fusion or an arthroplasty, I would counsel them that the 5-year reoperation rates are lower with the arthroplasty. And I do think that's an important advantage. I talked about the 5-year results. 2-level arthroplasty 10-year results in the cervical spine have also been published. And the findings in this 10-year study were pretty similar. The adjacent level reoperation rate in a fusion at 10 years is 18%. The adjacent level reoperation rate for the arthroplasty at 10 years is 9%. So it does appear the clinical data supports that preserving motion seems to mitigate or reduce the reoperations at adjacent levels. So what about multiple level arthroplasties? We've talked about the 2-level arthroplasty. What about 3-level, 4-level cases? Okay, so typically what we're seeing is in the 2-level cases that the arthroplasty has been proven safe out to 10 years. And most of the published studies show lower reoperation rates for the multiple level, for the 2-level arthroplasties. Now, if you do a meta-analysis of all of the studies, the 10-year level 1 data shows that cervical disc arthroplasty is superior to fusion at up to 10 years for reoperation, for implant-related adverse events, for adjacent segment degeneration, and for neurologic success. So that's the 10-year data. And if you're counseling a patient on arthroplasty versus fusion, you can tell them with confidence that the 10-year outcomes data suggests that the arthroplasty, if you're a candidate for the arthroplasty, is probably a better surgery. It seems that with the data published over the last 10 years that cervical arthroplasty for patients with degenerative disc disease and who are otherwise healthy may in fact be the new gold standard for treatment of degenerative disc disease in the cervical spine. All right. I'm going to talk about hybrid fusion and also about lumbar arthroplasty in a moment, and I think I'm on track. I only have a few more slides. With respect to hybrid surgeries, a hybrid surgery is a surgery where, for example, you have a 3 or 4 level fusion, and one or two of those you have a 3 or 4 level surgery, and 1 or 2 of those levels is a fusion, and 1 or 2 of those levels is an arthroplasty. So you're combining fusion and arthroplasty in the same patient. So that's a hybrid surgery. So obviously that's the type of thing that people would want to study a little bit more. And in the computational analyses, the finite element studies that have been published on this, it's been shown if you do a 3-level surgery and 2 of those levels are fusion, 1 of those levels is an arthroplasty, in the arthroplasty group, in the finite element study, the arthroplasty group has lower adjacent level stresses compared to the all fusion group. And in addition, in the finite element studies, there's no unusual stresses or the computers have not found any biomechanical contraindications to doing the hybrid surgery. There's not as much published literature on hybrid arthroplasty fusion surgery, but Zhang and colleagues published their series of about 50 3-level hybrid cases. And in the group that had an arthroplasty fusion, there was less adjacent segment degeneration at 2 years follow-up as compared to the 3-level fusion group. So that's not very good data because it's not a level 1 study and it's only 2-year follow-up. But for hybrid surgery, it's some of the best clinical data we have. Another group in 2014 published their series of 30 patients who had 3-level hybrid surgery. And in the patients who had the arthroplasty incorporated into the fusion, there was a trend, but not statistically proven, but there was a trend towards less adjacent segment degeneration in the arthroplasty group. Statistically, it did not reach a p-value of 0.05, but once again, as I said, this is the best data that we have. It is not the quality, it is not the level 1 quality of data that we have from the FDA IDE studies. For lumbar spine arthroplasty, we do have 10-year follow-up data on some of those implants. And in JBJS in 2005, Marne from France and some of his colleagues published their 10-year results on 55 patients who'd had a single-level lumbar disc arthroplasty. In that series of 55 patients, there were 0 implant failures at 10 years. 41 out of those 55 had excellent or good results, and 14 out of those 55, 30%, had continued back pain. So the results, the clinical results of lumbar arthroplasty as compared to cervical arthroplasty are not as good, right? If you do the lumbar spine surgery, in general, in lumbar spine surgery, the results are not going to be as good as they are in the neck. As a spine surgeon, you typically are judged on the outcomes of your patients who have the cervical spine surgery. Because if you have surgery on your neck, patients and the population expect all those patients to do very, very well. So if you're a good spine surgeon, then all of your neck patients in general are going to do very, very well. The results in the lumbar spine are not as good, and that's just the nature of lumbar spine surgery and the nature of the literature we have. But the 10-year clinical data from this study did show 0 implant failures and good results in about 70 to 80% of patients, and as I say, about 30% of patients had continued back pain. And that's another one of the cautions about operating on back pain, right? When you operate exclusively for the reason of back pain, then sometimes the results of surgery are, well, they're just not as good, and that's a fact. For lumbar spine arthroplasty, this is an X-ray, a representative X-ray from Marne's series. This is one of Marne's patients, and this is an initial immediate post-op X-ray. You can see 10 years after surgery, the lumbar disc arthroplasty implant looks like it's doing just fine. And that's probably what you'd expect from the biomechanical studies, from the simulator studies, is that if you do a lumbar disc arthroplasty or a cervical arthroplasty, the wear rates are very, very low. That's in contradistinction to the hip or the knee, where the wear rates are 10 or maybe even 100 times higher. So mechanically, the arthroplasty implants do seem to hold out, at least up to 10 years. Formica and several of their colleagues, I think in Sweden, published a series of 20-year clinical series of patients who'd had a lumbar disc arthroplasty. So they did lumbar disc arthroplasty starting about 20 years ago. Average follow-up in this series was 14 years. And in this, this is the longest follow-up study that I've seen. In this series, with a maximum 20-year follow-up, there is a 10% rate of revision surgery of the arthroplasty level after 20 years maximum follow-up. So at some point, they are going to start failing. We believe that the arthroplasty implants are going to be very durable, but they certainly are not a perfect solution. Okay, so this is a case example of a recent case. This is a 4-level hybrid case, and you can see here that you've got an extension X-ray, flexion X-ray, and then a neutral X-ray. This is a 4-level hybrid cervical case. You can see clearly that it does preserve motion. Doing this sort of a hybrid surgery is supported by the clinical data, and we believe but cannot prove that incorporating the arthroplasties into complex spinal surgeries may reduce adjacent segment reoperations. For the lumbar spine, if you're evaluating a patient with a lumbar spine pathology and degenerative changes at multiple levels and who is symptomatic, if a patient has degenerative facet joints, as we discussed earlier, the lumbar arthroplasty and the cervical arthroplasty preserves motion. So one of the principles of the surgery is that the rest of the spine has to be pristine. So if you have a patient who has a spine who's got degeneration in the facet joints, okay, this is the L5-S1 level, then this level is not going to be a candidate for an arthroplasty. On the other hand, the level above, which does have well-preserved facet joints, may be. So a patient like this can be treated with a fusion at the level that's got facet joint arthritis, and the level with good facet joints can be treated with an arthroplasty. And the clinical data that we have suggests that many of these patients will do very well. So in conclusion, In the cervical spine, the prospective randomized trials show that in the cervical spine, cervical arthroplasty has less adjacent segment degeneration, less adjacent segment reoperation, and also lower reoperation rates overall as compared to fusion. That's a 10-year follow-up. In the lumbar arthroplasty data that we have, which is not as good as the cervical data, the long-term studies show low revision rates. And again, that's not level 1 data, but the long-term studies show that they are pretty durable implants. The biomechanical wear studies that we have suggest that the implants should last many decades. And obviously the goal is that you'd want such an implant to last 40 years, the rest of the lifetime of the patient. Further long-term surveillance is required, but I think the takeaway point is that both cervical and lumbar arthroplasty are here to stay, and there is some potential that they may lead to reduced reoperations later in life. I thank you for your attention, and I'm happy to take any questions. Yes, sir. That's a great question. Lumbar discogram, unfortunately, is fraught with controversy. And the problem with doing discograms is that they're a very subjective test, because you infiltrate the disc with a pressurized liquid, and then you ask the patient, is this the same type of pain that correlates with your back pain? And then the pain management provider or the specialist who's doing the discogram, whether the specialist injects, there's no guidelines or uniform guidelines on what the right amount of pressure is to infiltrate. And the end result is that it's very difficult to interpret the results of a discogram. So in my practice, I do not order discograms. What I do is I rely on the MRI and the CT scan and the patient history. If a patient has failed at least 6 months of conservative care and has isolated degenerative changes involving the discs only at 1 or 2 levels, and there's no legal issues, no other secondary gain issues going on, then those patients may be a good candidate for an arthroplasty. And in my experience, those patients have done extremely well. I'm not sure I really answered your question. Okay, sure.
Spine practice per se, but I do see neck patients from time to time, active population. What is your advice to them? So for instance, if you got a 38-year-old male that runs marathons, otherwise healthy, let's say they get a 2-level disc replacement, what do you tell them their expectations should be after they have that?
The purpose of doing, we tend to do these disc replacements in younger, more active people. And the purpose of doing the disc replacement is, to help these patients maintain, an active lifestyle. So what I tell my patients is, you've got a mechanical device in your lumbar spine, and I counsel them to continue to stay in shape. If they're runners, I would suggest they continue running. But if they're trying to do really aggressive, high-impact activities like playing football or higher impact contact sports, I would counsel them that you've got a mechanical device in your spine, and I would suggest you should try to protect it. And so I try to strike a bit of a middle ground. But without a doubt, the purpose of doing the arthroplasty is to maintain an active lifestyle. So I definitely tell them to continue going to the gym, continue running, and try to do a little bit more low-impact physical activity.
Thank you.
Okay, thank you very much for your time.